All right, awesome. Thank you. Let's get started. So this is going to be the second part of the cardiology diagnostic testing. The first part we went pretty much through a lot of the stress tests, but I wanted to give this as an opportunity to kind of review what we talked about last time. So the major breaking point was if patients can exercise or not, right? If they can exercise them. The real question is then really what imaging modality are you going to use to decide if that exercise induced any potential ischemia, whether it's going to be an EKG, which is that first option, or adding an echo, which is going to tell you more about the valvular function, or even SPECT or nuclear imaging, which is going to be a lot more sensitive than that treadmill, but it's going to come at not only a cost, but the nuclear exposure. But if the patients can't exercise, then we need to add pharmacologic options, whether it's the vasodilators or the beta agonists, knowing that our beta agonists, such as dobutamine, are ones we want to try and avoid in our patients that potentially have underlying COPD or asthma, whereas our vasodilators like regadenoson or adenosine, we can still use. And then with that as the stressor, then we still have the same options that we have with the exercise, whether it's, except for EKG, you don't do that, but we can do the SPECT nuclear, a PET, very expensive, but it has really good sensitivity, as you can see there, versus an echo or a CT MRI. So it's just a quick review of what we talked about last time. So if we were to put it all together, and I think we still went through some of this, but I thought that it was still good to kind of go over just to refresh your memory about what we talked about was, if the patient can exercise and they don't have any abnormal baseline EKG findings, what we talked about previously, then you can do an exercise ECG. But if they're able to exercise, but they do have some of those findings, such as maybe a prior MI, so maybe some Q waves already noted, they have delta wave with Wolff Parkinson White, baseline ST depression, so they're taking a medication such as digoxin, which already will affect the ST segment itself, or even LVH, then you want to add some perfusion imaging onto that, whether it's going to be your echo or nuclear. But now if we can't exercise them, and they have a left bundle branch block or even a ventricular paced rhythm, then go ahead and go for the echo. And then you're going to do the nuclear, even if they have those above findings, but some of the things that might affect the sensitivity or the ability to truly read a good echo, meaning they're obese or they have an abnormal baseline heart rhythm, such as AFib or aflutter, those would be reasons to not do the echo, but instead do the perfusion testing. And then as we talked about on that right side of that flow chart, if they have a condition such as COPD or asthma that might get exacerbated by giving them that beta agonist, you want to try and avoid that by doing dobutamine. So this is a table that I created that kind of puts a lot of this information together. I'm not going to go through each one of these, but it kind of gives you in a graphical format. PTP stands for the pretest probability. So as you know that we ideally want them to have an intermediate pretest probability because that's going to be our perfect zone. But if they have a high pretest probability, that's when the angio is coming into play, because you're like, well, if you already suspect it's that much, you might as well just go ahead and do it. But in patients that have concurrent, maybe COPD or other conditions that might cause abnormal or non-specific presentations, and if it's not angina, and maybe it's just shortness of breath, then that's where you can still do these stress echo or even the cardiac magnetic resonance imaging. But if someone has more of a low to intermediate range, then that's where you're going to still do your less invasive and less costly options, which might be your stress echo or ECG. And that's in symptomatic patients. But if you have asymptomatic patients, then your options are very limited, right? Because the question is, why are you even testing them if they don't have symptoms? We're going to get to that with the cardiac CTA and even our cardiac coronary artery calcium scores when we're doing a risk stratification. But you can use the ECG as basically your asymptomatic evaluation. If you want to do an exercise ECG, you can, but that's why sometimes we'll get just ECGs at baseline to see with these patients. But you can see the blue is kind of like there's not really good data as well, and the red is that's really not recommended at all in those patients. So we went through these questions last time. I just wanted to go through those slides specifically because I thought it was a good review. So again, the questions to consider: what's the pretest probability, we just talked about? Is there any reason why you have to hold specific medications like a beta blocker? Make sure you do if you're especially giving them a medication like a dobutamine. Can they exercise or not? Because that's going to be your major branching point. And then once you decide if they can exercise or not, then the next modality, the imaging, whether it's an ECG, echo or nuclear, is going to be based on a lot of that resting ECG with some of those baseline abnormalities which you talked about or lack thereof. And females, consider adding imaging in general because they're more likely to have false positive testing on ECG testing. And then you can look at the cost as well, especially in our Medicaid or even private payers. You don't want to just go straight for the PET or the SPECT imaging. While it might give us more information regarding increased specificity and sensitivity, we might not necessarily need all that if our pretest probability is high. So how to choose, we kind of went through this. It was just a summary. So I'll kind of fast forward through this information because it's just summarizing the same information just in different ways. So let's go for the summary before we go on to some of our specific imaging as the second part. You're going to use that pretest probability to determine the risk. And remember, we talked about the Diamond Forrester, the CAD consortium, even the heart score, which is pretty much done in the ER setting. Once you've decided what that pretest probability is, then you're going to decide, should you test that patient, how you're going to stress the patient. If they're low risk, we're going to stick to the ECG treadmill. If they're intermediate, that's where you can bring in the nuclear and even the echocardiogram modalities. If they're high risk, you're going to consider going straight to cath unless they have an atypical presentation such as shortness of breath or dyspnea exertion. I guess I shouldn't say atypical, I would say non-specific or cardiac specifically symptoms. And that's when you might want to go still to doing stress imaging, not necessarily the cath, because it could be maybe their pulmonary or their lungs that are the source of their symptoms. In patients that have a normal baseline ECG and they can exercise, ECG is always going to be your option. You know, Dr. Duffy is credentialed in that, so he's one of our providers that does that. So just know that this is what an option. You should always have answers for your boards. If the patient can exercise and they have a normal baseline ECG, that's always going to be the best option for them. And then understand that there's other imaging modalities that are going to give us more functional information, like the echo about the valves. And then the nuclear is going to give us more information about the more sensitivity and specificity for our results. So let's go over the cardiac MRI specifically. We do this here at Parkview. Dr. Garcia is the cardiac MRI person. What are we going to get by doing a cardiac MRI? I mean, again, it's very expensive. There's no radiation involved, but it's going to tell us about cardiac masses. If there's a non-ischemic cardiomyopathy, maybe we think this is a long-term myocarditis. You know, potentially we can see some troponin leak in these patients, and we don't think this is from an elevation from an infarction. We think this is from a viral infection. So this can tell us about that, as well as infiltration conditions like sarcoidosis and amyloidosis or hemochromatosis. But again, it can still tell you about myocardial infarction, but I argue that that's not the reason you're going to get a cardiac MRI. You're going to get it for some of these other things that you think might potentially be confounding the process. Or if you think there's coronary artery anomalies that are present that might affect their ability to do the cath, if they have a congenital heart disease. This is, you know, if the patients I'm taking care of at CSU Pueblo, this is something that I considered ordering in one of our patients, not necessarily for HOCM. There's one guy I'm ruling out right now for that using echo, but we had a guy who was recovering from coronavirus and he had documented coronavirus and he was still having some chest issues. And if you look at some of the newer literature that's coming out of ACC, while it's not slammed, oh, can you full screen? Okay, so you can't, are you guys not seeing my, I guess you're probably only seeing, okay, sorry, I thought I was full screen, I apologize. Let's try this. Can you see that okay? The full presentation now?
Yes.
Okay, thank you. So I didn't realize I was not full screened. All right. So in this patient, he was still having symptoms, and coming out of ACC and some of the sports medicine guidelines, they've suggested that myocarditis might be a viral etiology that we should consider in patient athletes specifically that are persistently having chest pain. But it's an expensive modality, and they've gone back and forth regarding just trending troponin levels, ESR, CRP, as well as an echo. So I chose to do the troponin and echo, and I'll tell you, it's one of the few times in my career, which is short career, but you know, that I've actually ordered a troponin on an outpatient, right? You should be doing it if you think there's clearly a STEMI or NSTEMI going on. But in this situation where I wanted to make sure there was no evidence or suspicion of myocarditis, that's why I did that. So start looking at cardiac MRIs as potentially being an option if you have young athletes or young patients and you're worried about them potentially having persistent symptoms after coronavirus. So let's talk about cardiac CT. So what are your options? You have two types. You have the coronary calcium score and the coronary CT angio. I think even going back to 2 years ago where I was kind of reading a lot about this, it's still somewhat debated if we're truly getting this testing for what it was intended to do. And my argument would be that we're not, that we're actually extrapolating this testing into areas of patients that it really wasn't intended to be used on. And I'll get to that in a second. But what I mean is, it was really for asymptomatic patients. So coronary calcium scoring was meant for looking for obvious coronary calcium. So here's a CAC score of 0. There's clearly nothing lighting up. But in a patient that has a CAC score of 1200, you can see all this calcium lighting up here and even around here in the aorta. And what they were finding is that the intent was For patients who have a strong family history of some premature disease or patients at an intermediate risk, then you can use it to help decide what medical therapy you want to do. So some of you that have, stats patients in the clinic with me, we've talked about it. We haven't actually gotten it, but if you had someone who said, I have a family history that's very strong, cardiac disease, early cardiac deaths, what have you, and maybe they have high lipids and LDL, maybe 160, and they're in the intermediate range when you do the ASCVD risk score, but they do not want to get a statin added on for whatever reason. Or maybe this would be a patient that you want to start aspirin on for prior prevention, even though there's been a lot of debate about that in the past year to a year and a half. This could be an imaging modality that you could use to help figure that out. Coronary calcium score is also used for intermediate ASCVD risk score. Which is what I was kind of just saying. So you can use aspirin and statin when you're having that discussion with patients. You can get this score and say, hey, I can show you the actual calcium you have built up in your heart, or I can give you the score, which we'll go over to show you maybe that's going to push them into that range of, okay, now I'm okay with getting that statin added on. The CTA, or the coronary CT angio, is also good for intermediate patients, especially those who cannot exercise and they have an abnormal baseline ECG and maybe they don't want to get an echo or a nuclear scan. So its greatest role is to kind of rule out coronary disease if someone has an intermediate risk, but you're not absolutely sure that this is true cardiac pathology. Just like more of our contrast CTs, you just inject it into the vein and it goes through the rest of the heart, and then they look at the images to see if there's atherosclerosis, but they can't see stenosis. So you're not doing this for patients who you have a very high pretest probability, because if you do, they probably already have some stenosis going on, and it's not going to be able to find that, but it's going to be able to find some atherosclerosis. So the stenosis was brought up yesterday on our journal club, where we talked about, Pat went through that physiologic changes that we see where eventually that plaque will rupture. So we're not looking for stenosis, we're looking for just atherosclerosis. And it's useful in patients with atypical chest pain. So you're looking to exclude blockages. Again, you're not going to find blockages. So you're looking for those patients with atypical chest pain, but they're still at an intermediate risk. Like, I don't know if I really want to do a stress test in them, whether it's cost, timing, whatever it might be. You might see a lot of hospitals, depending on where you all eventually work at, that use, and I know the residency that I was at, we use CTA as a good option in ruling out our atypical or chest pain rule outs in patients that we admitted for observation. It was faster and easier for us to get cardiac CTAs than to get stress tests on those patients. So that's when we would use it. And then looking at coronary calcium scoring more in depth, more than what I just talked about. Again, it's on also a risk stratification. I'm not going to read this bottom because this is just talking about that known physiology that we are understanding with the fatty streak that eventually leads to the necrotic core and then the calcium depositing there. But again, knowing as the calcium deposition gets larger, that's when the imaging can find it. So it's going to be looking for a risk stratification. I'm going to skip this. No, I'm actually not going to skip this because it's going to show you how to understand how the score correlates with what we're seeing physiologically. So in the beginning of when we start having the atherosclerosis develop, there's no plaque. You're going to see a CAC score of 0. As the calcium progresses and it forms this lipid core, you're going to see that it's now called non-calcified because it's just lipids. It's not actual calcification. So you're still not going to see it on the imaging because, again, this CT imaging right here is only going to look for the actual calcium that's bringing up. So there could be that lipid deposition present, but you're not going to find it on that imaging. All right. And then as you get to the type 5, and now it starts having some thickening, it's going to start showing up. So you can start seeing this whitish area here. You guys should be able to see my mouse where that calcium is starting to develop. And as a result, now we're starting to see that score go from 0 to 100. And that's going to affect what medications we recommend, whether it's aspirin or statin, which I'll talk about in the next few slides. Once we progress from type 5 to type 6, now we can see there's calcium all over. And now there's even a thrombus that started to form. There's clear rupture of this thrombus and core, leading to even a hematoma forming in this area. And now we've had a calcium score of greater than 100. So these are patients that probably are presenting with symptoms, but maybe they could be asymptomatic as well. But these are the ones you're clearly going to see a high score. And as we go from type 4 to 5, or 6, I should say, we're seeing that cardiac mortality risk is increasing because that plaque and that rupture is just getting worse and worse and worse. So the scoring system is the whole point of this slide was to tell you that Just because someone has a coronary calcium score of 0 does not mean they don't have some development, because again, the point of this is not to necessarily find this, it's for risk stratification for these patients if you're going to put them on aspirin, statin, or both. So again, you're looking for the calcium deposits and the atherosclerotic plaque in the arteries. It's going to be helpful for these subclinical patients or patients that have subclinical disease, that type 4 or type 5, because you're going to start seeing a score of 100 or less. It's very helpful in women because they might not present with the traditional presenting symptoms of angina that we expect, right? We know very early on in medical school, and even hopefully during residency, we're teaching you that when women present with symptoms, those are the ones I get concerned about because they don't present with their classic symptoms. And always remember, if they've had a heart attack before, you clearly would not use a coronary calcium score. CTA, coronary calcium score, should not be used in patients that have known heart attacks in the past or have known cardiac disease or coronary disease. But if they don't, you should start having a high suspicion for especially women because they don't present the perfect way for us being able to risk stratify them. So this last sentence or paragraph is the most important one. It's a tool for traditional risk factors, such as that 10-year ASCVD risk, to better accurately estimate our patients that already have a 10-year risk that we've calculated, so we can implement some risk-based strategies, whether it's aspirin, statin, or both. So that is the intent of this, is for subclinical patients, patients that not necessarily present with the same symptoms, but we're doing it from a risk stratification standpoint. So who do we test? If you go all the way back to 2013, doesn't seem like it was that long ago, but this is already 7 years old. What they said is the coronary calcium score is done where it may appear that the risk-based treatment decision is uncertain after you've done that formal 10-year score. So a score of 100 or more, you're going to do the aspirin. If they have a score greater than 0, you're going to consider that statin. So again, let me go back to this slide. So if you have that score of 0, we already know that there's some lipids depositing there. So you're going to add that statin on. Once you have this calcium deposition with the plaque forming and then the rupture, that's when we're going to consider that primary prevention with aspirin added on. So this is an important slide for you guys to know. I was trying to find, I think a lot of this controversy behind this is because these guidelines are so old. 2013, 7 years in the cardiac world or cardiology world was very long, to be frank. So in 2016, that's the latest official guidelines I could find from the Society of Cardiovascular CT. And what they said was asymptomatic patients at intermediate risk of 5 to 20%, that's when you do this coronary artery calcium score. Because you're trying to find, is there another reason why you want to add a statin onto them? That if you need some other imaging modality to convince them. I'm doing work with Dynamed and stuff about creating these kind of different scoring systems and tools to help give patients a better understanding of why we do certain things. And this might be something you need to show. You might need to show the patient this actual imaging and say, hey, I can see clear plaque on the arteries that are depositing or that are supplying your heart. This is why I want to start you on the medication. And I would say in my experience, imaging is a lot more powerful than just showing text. And then I would say numbers are the next most powerful thing after that, showing their actual 10-year risk of developing heart attack, stroke, or what have you. So how do you use it? You're going to first identify the ideal patient, someone that's 45 to 84, someone we can use that 10-year ASCVD risk score on that has risk factors, but they don't have true anginal symptoms. And then you're going to calculate the 10-year score on them. And if the patient is at the intermediate risk of 5 to 20%, then you can consider performing the coronary calcium score. You might say, hey, Mr. Smith, I think that we need to put you on a medium intensity statin. No, I don't want to be put on that. Okay, well, would you be adverse to us doing some imaging to kind of see what we're dealing with? Because maybe you get a score less, 0 or above 0 is where you're going to do a statin. So maybe you see a score of 0 and you're like, okay, you're right. Maybe we don't need to do that. But you can do that, the 0, no atherosclerosis, 1 to 99, this is where there's mild disease, you're going to put that statin on. Once you get above 100, you're going to put the aspirin on. If you have someone that's greater than 400, then they're hopefully, if you did it the right way, they're presenting atypically. And you're going to have a higher suspicion now if they start presenting with shortness of breath, dyspnea exertion, no smoking history, COPD history, etc. Maybe you should have a higher underlying concern for cardiac disease. For some reason, I'll get to these in a second. So the score, again, is based on the area of calcification for each cross-section that's done on this. And then it's multiplied by a factor. You don't need to know all this. This was just to be more in depth than necessary. And then what they do is they sum all these areas of calcification that they find in the RCA, the LAD, and then the left circumflex to give this Agatston calcium score. And then when you get that score, you get one of these ranges. So you plug that score into the MESA calculator to determine the level of calcium deposition for patients in that same age, gender, ethnicity, kind of like the T-score that we use when it comes to our DEXA scans. And so when you get this underlying score, then you're going to plug it into the calculator, and then it can help determine what your plan is. You're going to be initiating an aspirin, or if it's greater than 0, putting in a statin. Okay, so just know about that MESA calculator, that it exists. I don't think it's probably going to show up in your boards, but this is more clinically relevant. Given the high negative predictive nature of the test, though, you can use it to help predict patients that have symptoms beyond the traditional risk factors. So they might not be presenting with traditional risk factors, kind of reiterating what I've already talked about. Those elevated calcium scores will, again, lead you to deciding if you want to put a statin or aspirin on. You're really not going to be doing it in your symptomatic patients, okay? So your asymptomatic patients that have a high risk, whether it's in their family history or even in their personal history, or I'd say low to intermediate risk, not high risk, you can consider the CACS. If they have atypical chest pain and they're presenting to the hospital and you're admitting them for this, cardiac rule out, that's when you can do the coronary CTA, 2 different things. I don't know what that noise was. I don't know if, how long does the study take? Both the coronary calcium scores and the CTAs are just like CT, so they're very quick. They're done in a few minutes. It's the interpretation of them that usually takes more time. I would say that from when I've talked to radiologists in the prior places I worked at, not the ones necessarily here, but the nuclear takes a lot longer for them to read than it does for the coronary CTA, because the computer does all this work for them, as you can see in this printout, and then it prints out the number. So literally they're just dictating what the number is showing. So these are very fast to do, which is why we use the coronary CTA as a way to get rid of our I don't want to say get rid of, but discharge our OBS patients faster. Those last thing, no randomized control trials have been done to evaluate the preventative impact based on these calcium scores. So what they mean is, if we were to use this and then allow us to then decide if someone needs to be on aspirin or a statin, they haven't done long-term RCTs to see did that actually help the patient or not. So this is all presumptive, like, well, yeah, if we see something, then physiologic, based on this picture that I showed you back here, that it makes sense why we should start a medication, but we just don't have long-term data to prove what we think is of a benefit. There's 2 different types of reasons or information you can get from that CACS. It can be used from a diagnostic perspective and even prognostic. So you can see the chance that they likely have some angiographically significant disease based on how high that score really is. But you can also use it for its negative predictive value, because a negative score, no calcification, is very much associated with a low risk of having any obstructive disease, because you would expect that the obstructive disease is going to be from calcium. So if you're literally not seeing calcium, and that's not much of an subjective thing, that's an objective finding that the computer is going to find, then the odds of them not having it are pretty low. So the best time to use it is that intermediate risk. Again, hammering the point home, intermediate risk patients, the ones that you kind of use it. But it can also be prognostic, because if you do see a score greater than 0, you know that there's some lipid deposition that's already happened. So the risk of developing something is pretty high. In this study from Shaw, they found that patients without symptoms, so with elevated scores, had a higher all-cause mortality at 15 years than those with a score of 0 itself. So they're able to look at long-term, what was the chance of these from a prognostic standpoint, these patients developing some cardiovascular event. And Nasser actually found out that increasing mortality rates seem to correlate pretty well with these scores. I found this specific because it was a question I had. I was like, well, we see the scores back here that I talked about, but does that actually correlate with clinical outcomes? Just because the computer says it's mild or moderate and they've created these numbers. I wanted to know, why did they come up with those ranges? And this is why, because they found clear associations with percents. When you have a score of 0, pretty much no risk at all from an annual perspective, which is why that negative predictive value is so high. But once you got from 1 and above, you could see an exponential increase to greater than 400, almost 20% annual mortality. I would say that's a very powerful number to give your patients, a 20% risk of mortality, not even morbidity. So very high. This was a very interesting study. I have it at the very end of my reference slide. But just to correlate the numbers that we're seeing with our CACS and potentially the outcomes for these patients. What are the benefits? Well, there's no radiation. There is radiation exposure, but it's not that much. It's just a very quick CT test, very cheap, less than $100 in most cities. So very cheap compared to your nuclear testing, and it has very good negative predictive value. But there is a risk that there is false negatives and even false alarms, because the calcification in the coronary vascular does not necessarily mean that it's clinically relevant. All right. So even though it sees calcification, that does not mean that that patient is going to have clinical symptoms. So again, you're doing it for risk stratification, not in patients who are coming in with symptoms. All right. This is an example of a false positive that I found in a case report. So this is a patient who was found to have significant score of greater than 3,000. So when we go back, we saw that a score of greater than 400 was almost 20% annual mortality. So this person had 3,000. You're like, oh my gosh, is that the cost of? Yes, that's after insurance, Max. So when they did a nuclear test on this person, you might argue, I don't know the actual scenario if they should have just gone straight to cath, but you could have argued maybe they should have just done a cath, but they did nuclear and they found that if you compare the donuts top and bottom, there's really no change that we're seeing. So this is completely a negative scam. So again, it's not a perfect test, but given the lack of significant radiation exposure and the cost, it's definitely something you should have in your toolkit. But this is an interesting thing, and this came out in JAMA in 2017. Is it a replacement for functional stress testing? We know that's a lot faster. It's not going to require as many people, so it's going to be cheaper for the hospital as well. They did a meta-analysis of 13 trials. They included a lot of patients, over 10,000, of those presenting with symptoms consistent with ACS, but they had a normal troponin EKG. So, and even those with stable angina. So we thought this was unstable angina, but it was not a NSTEMI patient or a STEMI patient. A lot of these patients, we will say when we consult cardiology, if we do, they'll say, I'll just do a stress test and let's see if we see anything that's functionally noted that would warrant the risk of doing a cath. So that's what they did in these patients. They found that patients undergoing the coronary CTA were more likely to receive a diagnosis of new coronary disease and be started an aspirin statin. And they're also more likely to undergo invasive coronary angio than those undergoing functional stress tests. So it is suggestive of more of a false positive. These patients underwent more invasive testing than they would have undergone if they did the stress testing. But it's not just false positive, because some of these patients actually underwent revascularization. So they found clinically significant coronary stenosis. In case you are asking people questions, okay, that was Cells is having issues, I guess, with Zoom. Sounds like she's lying, but that's okay. So coronary CTA was not associated with an overall reduction in mortality and cardiac hospitalization. So what they found was, even if we compared coronary CTA to our patients who had stress tests for the same kind of presenting symptoms or cardiac rule outs, they didn't seem to have a mortality benefit. There was no benefit of doing that over the functional stress testing, but it wasn't worse. Right. So it was it was non-inferior. So you might use this in general. There's mixed results for this chest pain rule out, but you can consider it as an alternative if there's maybe an issue with cost or timing for getting these patients out. Consider the coronary CTA, not the coronary calcium score. I should have changed the title. That's a little misleading. So the coronary CTA was a good option in helping get these patients out of the hospital faster. So the take-home point is, in patients that are deemed low risk with no previous CAD, you can use, and I would say even intermediate risk, you can use that coronary CTA to decrease the length of stay, but understand that it's going to increase that risk for downstream testing. Remember, these patients underwent more revascularization, but there was no benefit in general for mortality, MI, MACE. In the ER, we do direct cardiac stress tests with patients of moderate risk. Yeah, and I think that's appropriate. I would argue that it's dependent on the ER specifically, but some ER physicians are comfortable doing that testing to then get them out. That was honestly the whole point of an observation unit when you look at it when hospitals were built. It was managed by certain sides of the ER, and they were able to get these patients out faster because it was cheaper for the insurance and for the hospital. And we've kind of gotten away from that. I wouldn't say at Parkview, but in general, because maybe there's a liability concern, or maybe there's just not a big enough ER. So that was the intended point for that. And then cardiology takes them directly up, then back down. Yeah, so there's really no need in this scenario for internal medicine to get involved, but that's hospital specific. So those are good points, Max. I'm not going to go into this detecting instant restenosis. Just know that you really shouldn't be, you should always have it as a concern. They did one study that was very small, 226 patients, that's found that potentially was good for ruling out in-stent restenosis in patients who already had a stent. But I would never use this study given how low of a sample size it was for actually directing any meaningful changes to my practice. So that's why I really don't want to talk too much about it. Okay, I guess we'll talk about this. So let's do a sample case. A 55-year-old male presents for his annual physical. He comes and sees you just maybe to establish care, and he's found to have a 10-year ASCVD risk of 7%. So, between 5 and 20%, he's in the intermediate risk category. You do an extensive conversation about lifestyle modifications and even medications that might help, like aspirin or statin, but he's very reluctant to initiate these measures, and he's otherwise asymptomatic. So would calcium scoring be reasonable? Absolutely, Dr. Grondike. So it is, because that his intermediate risk, he doesn't have other atypical symptoms. So this would be a great, and he's a little initially reluctant. So this would make an option to see if his score is 0 or greater, or a score greater than 0, put him on a statin. And then once he gets to the 100 range, potentially considering aspirin. What about a 50-year-old male who has a family history of CAD, is an active smoker, has diabetes, presents to the clinic with 2 months of exertional chest pain that resolves with rest? Would you want to do that coronary calcium scoring in this patient? Yeah, I wouldn't do it. So this patient's symptomatic, so you would not do that. You should go off cardiac biomarkers, probably admit this patient and do either a stress test or go straight to a cath. I think this is the last one. 30-year-old woman, no medical history, presents with on and off chest pain at both exertion and at rest. Her ECG is unremarkable. Cardiac enzymes are negative. Would coronary calcium scoring be reasonable? This is a hard one. And I feel like you guys could argue either way on this. So Menakeb says to stress. Dharmisha says no. Mina says stress test in this one. So this story is not typical for coronary disease, but she has a low pre-test probability. And again, that coronary calcium score is not going to help because of how young she is. Remember, I gave you that. So I agree that stress testing would be amendable in this option because she's young, but you don't really know what's kind of going on with her. I would probably do an ECG stress test in this person, right? Exclude non-cardiac causes. Absolutely. So this is kind of a sampling bias because we're talking about, or a lead-in bias, we're talking about cardiac stuff. So you're not going to talk about potential external influences like underlying COPD, if she was maybe she has no medical history, so you'd be ruling on like GERD, some other things that could cause atypical chest pain. But in this one, since we're talking about cardiac testing, yes, you would exclude other causes, but we'd assume that what's the best test? I would do an ECG stress in her. So a summary, it's a prognostic for the coronary calcium score for asymptomatic patients to help decide further management, whether it's a statin or aspirin. But it's hard to know if the findings that we find in that coronary calcium score truly correlate with the symptoms that we're finding, right? And you might find more than you want to know. These incidentalomas, you might find pulmonary nodules and all these other things that might lead to not honestly unnecessary, but testing that we wouldn't otherwise have done in those patients. And then the cardiac CTA, I kind of went crazy on this. We've talked already a lot about it. Very high pretest probability. I spent a lot of time on it because I feel like this is the future of a lot of cardiac testing. So I just wanted you guys to know a lot about it. Sensitivity is very high, 93%, especially if there's a blockage greater than 50%, okay? So the sensitivity is gonna be dependent on how much blockage is present, but it's gonna help you rule out any evidence of CAD, because if there's no calcium deposition, you're not really gonna see it show up on a cardiac CTA. But there's very limited use in patients with AFib, PACs, or those that can't use beta blockers. So why do you think that patients with AFib that currently have AFib, or maybe they have frequent PACs or PVC burdens, would have issues getting a cardiac CTA? Anyone?
Is it just the ability to move the contrast out?
Yeah, because they're kind of gating this test, right? So they're using the concurrent ECG to kind of try and time when the contrast is in the coronary vessels. So yeah, I agree. It's the fact that there's going to be some motion artifact, but it's really going to be the fact that they're trying to time the PQRST with the contrast, and it's going to be hard for them to be able to get that P on there if that patient doesn't have P's because they're an AFib. If someone will get contrast, wouldn't it be better a cath as it's therapeutic if a lesion is found? That is a great question, Neil. And this is clearly going to be not a black and white discussion, right? That's going to be based on the cardiologist you talk to. I think it's going to be based on the time of the day, and it's going to be based on the patient and their pretest probability.
That, and Dr. Mathew, isn't it also because of just to kind of cut down the invasiveness of actually inserting that cath and running it all the way up versus just an image?
Yeah, absolutely. Because, one of the things they like to test you on is what are these complications that we see from cath? You can get a retrosternal bleed because there was a perforation. You have all kinds of issues. Maybe you form a fistula. Maybe there's an aneurysm. But when we used to do caths mainly in the femoral artery, the questions that came up on my boards were, you have a patient that had a cath, and then later that night they're complaining of worsening leg pain, and now you have a bruit that you auscultate in their femoral artery in vein. So there's clearly risks that come with a cath, and we don't just jump straight to them because that you have to balance that risk-benefit ratio. Diload, way different too. Yeah, absolutely. There's a lot more of a contrast exposure with a cardiac cath than there is going to with a cardiac CTA. So these are all great points that are going to come up that are important to consider when it comes to deciding what's the best imaging modality. And I guess one thing you can get out of this is a time where you might want to talk to the cardiologist and say, hey, I think that this patient we have maybe in the hospital would benefit from a cardiac CTA. What do you think? I've done it a few times, and I'm 0 for 3 in trying to get a cardiac CTA just because I think it's a cool test in the right patient to get. But it's going to depend on the cardiologist and how aggressive they want to be in those patients. So what are the uses? Again, you're going to get anatomic issue, congenital heart disease. You might see some septal defects, even PFOs or ventricular septal defects, bicuspid valves. It's going to tell you a lot of information, very similar to the cardiac MRI. Not as much of the infiltration, but you could probably still get some information about that. And acute chest pain in patients with an intermediate risk, this is a good option for them. Okay, so again, coronary calcium score, no, you do not use that when they're presenting the ER. You're using that for your clinic discussion. ER patients, this is a good option for that OBS unit. All right, low to intermediate risk, you're going to consider this. High pretest probability, especially end-stage or unstable angina, you probably want to go straight to angio. But as I discussed with that previous study, they have done some studies looking at the comparison of this with functional stress testing, and it's been kind of interesting, the results, despite this being cardiac CTA leading to more downstream effects, meaning they ended up having to get revascularization without significant mortality benefit from that revascularization. So because CT has that excellent negative predictive value because it's an objective imaging, and because it can be done very fast in the ER or in an OBS unit, it's hypothesized that it may allow us to eventually kind of use this as an option to get patients out faster than the stress test, which we talked about. I'm not going to go through the study. This is kind of another similar study where they looked at about 1,300 patients specifically at acute chest pain in the ER. And what they found that those with a negative coronary CTA did not die or have an MI within 30 days. So it had a very good negative predictive value. The CTA group did have a higher detection of coronary artery disease. Whether or not that was a benefit from a mortality morbidity benefit is up to discussion. But the study established that it's a safe alternative for ischemia testing. But I still think that there's more studies that we need to truly be able to change our overall, I think, habits of shifting from functional stress testing to cardiac CTA. I think it's going to happen, to be honest with you. It's going to take some time, but you'll see a lot of these studies, whether it's 2011, 2012, this was 2012, they've been done 8 years ago. We just haven't seen a lot since. And I don't know if that's because we've pushed a lot of the research more towards the fancy like MRI imaging, nuclear imaging, or what. But just know that this is still a modality, though it hasn't gotten a lot of attention, that you should be considering as options. The CT STAT, the Ramacat 2 trials looked at the same thing that I just presented, demonstrating that CTA based strategy led to lower lengths of stay, and there were, without lowering the safety, meaning these patients had a good negative predictive value. You weren't ruling them out and then having them come back within 30 days having had a heart attack, which is what the biggest concern is for ER physicians, which is why this is such a good test for them to consider. And we've seen it also been studied or supported in other studies. So let's do a quick summary. It's utilized in patients with low to intermediate risk of coronary disease presenting with atypical chest pain. It's going to miss those non-calcified plaques, because again, Lipid plaques that stage 4 are going to develop, but you're still not going to see much of an overall objective image show up. It's exposing patients to radiation, not as much of a contrast exposure that we might get with a cath. And like Neil kind of talked about, you're not going to get that therapeutic benefit. It kind of reminds me, it's not the exact same discussion, but when you're looking at colonoscopies versus, CT enterographies and patients wanting to do something that's not going to be as, I guess, traumatic as a colonoscopy, but they feel that it's just as good to get maybe a fecal occult blood test or get the CT imaging of the stomach. But I tell them, if it finds something though, you still have to get the colonoscopy for the therapeutic maneuver. But it's kind of a similar thing that I think about, but just know that it's not going to have any kind of therapeutic intervention. It's just going to give you objective info. But there's the question that really comes down to, is there any functional significance? And I think this is why we still continue to see the stress tests have a strong role in cardiac patients right now, is because of that functional aspect. Because we know that when we see patients that potentially have some disease on, whether it's the cath or what have you, it's important for us to know from a nuclear perspective or from an echo perspective, is that actually doing anything though? Because they might have plaque, but they might have completely normal wall motion. So would you want to risk someone to have and Pat was talking about MRC versus ERCP, absolutely too. It's very similar situations. So that's why the nuclear continues to be important, because we can see, is this plaque actually having any significant clinical effect to that patient? Or maybe their subjective symptoms are not having any objective findings on the nuclear and the stress or in the echo. So we're going to do a further workup, like Dr. Khan had mentioned, looking for some other causes. And it might miss disease less than 50%. Why? Because again, as I went back to here, the sensitivity is highest when the blockage is greater than 50%. So you might miss disease that's going to be less than 50%, but it's probably not going to be clinically significant, because cardiologists are not going to stent when there's less than 50% disease. Okay, ambulatory monitoring. So this is something that comes up very frequently, both in the outpatient and the inpatient setting. When we have someone who has a stroke, which we think is a cryptogenic stroke, or they're having palpitations, and we're trying to figure out, okay, do they have AFib that we've just missed? How do we find out if they have it or not? Well, we do ambulatory testing. Ambulatory testing, and I believe I'm talking about it, the 24-hour, we do the Holter, the event, and then the ILR, or the implantable loop recorder. So we're just looking at that patient's heart rhythm over certain periods of time. The times we're going to do it is like syncopes, palpitations, or when you suspect there's a cardiac cause for symptoms, but we're just not capturing it during the hospitalization. The major difference between all the different modalities is going to come down to how long are you actually recording them for, and how are you going to record them, whether it's an invasive device like an implantable or something that is wearing on the outside like a backpack. So again, you need to decide, what is the frequency of the symptoms? That is the most imperative question to ask. If they're having symptoms on a every 6-month basis, you're not going to do a 48-hour Holter, right? That makes no sense. You need to find out how frequent the symptoms are, and then based on that frequency, what testing modality is more likely to capture that. So you have your Holter. What are your different options? Your Holter and ambulatory ECG. It's portable. It's worn like a belt or even as like a lanyard in this patient. They use it during sleep and during normal activities. They can have a trigger. This one will not trigger. So there's just going to be monitoring throughout the entire time. If you have a person who has triggered symptoms, meaning, hey, I know I'm having these symptoms, I can feel the palpitations. Doc, what do you think that is? We're going to talk about doing a triggered monitor, but this would be for someone maybe like has syncope that's happening on a daily basis or every 2 days, or you just concerned they had a stroke and you want to see maybe in the next 24 to 48 hours, and you can do up to 2 weeks as well, are they having any bouts of atrial fibrillation, which would account for maybe why they had that stroke. You could also do a loop and event recorder. This is a patch that's kind of like a nicotine patch in a way, you can argue, that's worn on the left chest. It's just, the nice thing about this though is that it's up for 1 month though. So whereas the Holter and ambulatory is for up to 2 weeks, this is for the patients that have symptoms maybe once every 2 or 3 weeks. And it's used, again, if the arrhythmias are infrequent, the patient can trigger it. So they can press a device. I don't know, honestly, much about the technology, whether it's the triggers on the device itself. Some of them are now on the cell phones that can connect to the device itself so they can then correlate it with it. And then it goes to a central command center where they can then find out what that rhythm is. And then if it's obviously a very concern, he is much happier with this device. Yeah, he really is, isn't he? Let's go back to the, yeah, I guess he's a little happier, but he also has redder lips compared here. So maybe he has some exposure to like carbon monoxide or something, but, so the patient triggers it, it records a strip for 60 seconds before and then 40 seconds. I would argue that looks more like Pam and Tuan. That was the joke that we did last year. This was Patrick on these ones. He does have pretty luscious, nice professional hair, which I can relate to. But the events are eventually transmitted to the technician and they can act on the results. So if they see something over the next minute to a minute and a half after that's very concerning, they can call the patient and say, hey, you should go to the ER right now, you know, call an ambulance, et cetera. This is what the device, and then you have the implantable loop recorder, the most luscious, yeah. So this is a single lead ECG that can report for many months. So these patients that have symptoms that are going on, but they're very infrequent, this is something that can be placed as an outpatient procedure. Unexplained or infrequent syncope, but they've already gone through all this cardiac testing and it's been otherwise unremarkable to date. Maybe you're looking for AFib in a cryptogenic CVA patient, unexplained palpitations that are very infrequent. Or maybe you're looking to see after they had an ablation, if the patient is still having, what's the burden of AFib after that ablation. Maybe it's gonna help you correlate if you wanna continue anticoagulation in those patients. This has been studied in multiple trials to show that it's a very good option for leading to a faster diagnosis in patients specifically with unexplained syncope. So it's definitely an option you should be putting in your discharge summaries and discussing with your patients that come in with this symptom that seem to happen at least once a week or 2 weeks. We'll have someone presenting with that. And even our patients with cryptogenic strokes, they've studied it, but they saw that maybe there was a false positive. So maybe they were having it, but is that really the reason why they had their stroke? Or was it just that they have a fib and they happen to have a stroke, but they're not clinically correlated? So we don't know that enough about that just right now, but it's just something they found in some of these studies that I mentioned here in bold. And then let's go over to the echo. This is clearly something that Dr. Duffy is more of an expert with than myself or some of the other staff. But I hope I do it justice. Where it's the most common reason why we get an echo is looking at the left ventricular function. We can do it in a fast modality, whether we're doing it in the ER in a trauma situation, or we can do it on rounds like Dr. Duffy does as well to see more about what's going on with that patient specifically, or we can just order it and have the cardiologist do it. Indications, there's a lot. Arrhythmias, valvular disease, chest pain, we use it for everything. But just know that there's those complications, or I should say the limitations, obesity, COPD, things that might limit our imaging accuracy or the clarity of the imaging. It can help assess for hypovolemia, looking for the IVC collapse or maybe a hyperdynamic LV. We can look at it for tamponade, which we had that case reported, I believe, 2 weeks ago about, or even if you're doing a code and you're looking at cardiac arrest, or you can do an echo during a code situation to look at the heart itself to see if it's like quivering, et cetera. Advances in MRI, though, in cardiology have made it really an alternative, but it's really not going to replace the echo because of the cost and the fact that an echo is something that's portable, whereas the MRI requires a gigantic machine that many hospitals can't find. So this was discussed last Friday, I believe, by Dr. Duffy, where he did a very good discussion on echo and some of the ways to get the imaging and hit some videos. So if you guys didn't get that, it is on the private YouTube playlist. But if we were to go through each one of these different planes, we have the peristernal long axis or the PLAX. You're orienting that beam to the long axis of the left ventricle. So you're going to place that transducer in the left sternum, third, fourth, or fifth intercostal space. And this is the overall anatomic image. And then this is the ultrasound image in an ideal patient that has that probe. You're going to see that nice left ventricle with the mitral valve here, and then the right atrium, the left outflow tract with the aortic valve, and then you're going to get some part of that right ventricle into the picture as well. If we go into, this is the same thing. It's going to allow you to look for the pericardial effusions as well. So you can look down here or maybe see if it's thickened and concerned for maybe an infiltrator disease. And again, since you can see that aortic valve with the root, and he kind of showed us in that lecture, you can see the aortic, descending aorta coming down, you can look at the aortic root itself. If we look at the P-sacs, then we see that we're going to keep the transducer in the same location, just kind of rotate about 90 degrees. So it's going to be perpendicular. And as a result, we're going to get kind of a straight cut coronal type view. You're going to tilt that probe to sweep from the base to the apex, right? And what you're allowing you to see, if you correlate the anatomy with this image to the ultrasound, you can see that we can get a good view of the left ventricle and maybe look for a wall motion abnormalities at the septum or the lateral or inferior wall. And then we're also going to be able to look at the right ventricle. Oh, Dr. Duffy said he got some great PSACs views on a Team A patient. So hopefully if you guys get a chance, if you're not on Team A, maybe you can reach out to Dr. Duffy or some of the residents there to kind of find out what patient it was and take a look. We are using the ultrasound from 1 to 1:30 at most, just until we get the pocket. So if you're looking for it and it's not there, just go to 3 Southwest and we'll have the ultrasound there. It allows you to compare the views as well, the right ventricle, left ventricle. Maybe you're looking for a pulmonary hypertension patient. Do we have the cardio probe? Not that I know of. I know Dr. Duffy is trying to work on that to get us a cardio probe. Dr. Braden also has the butterfly, which I think is a better probe for being able to see the heart, but you have to check it out through her. So she has that, I think, in her office if you want to use the cardio specific probe. But if we go back to the PSACs, again, you're going to be able to get another view of the bottom inferior wall to look for like effusions, et cetera. And then you have the apical four-chamber. So the heart's going to kind of be sitting on top of its or the upper portion here, where now the left ventricle is going to appear on the right side. The right ventricle is going to appear on the left side. And you can see the apex. Again, you're going to be able to see effusions, but in the apical four-chamber, it's going to allow you to look for septal bowing specifically. So maybe in someone that has a PE, and this is a concern for maybe a submassive or a massive PE, then you can see some apical bowing. If you have someone that has HOCM, you could look for that bowing as well. You can even look for left atrial dilation. Potentially in someone that comes in with syncope and you're worrying about maybe they have atrial fibrillation, you might see a dilated left atrium, which may increase your suspicion of them having likely AFib. And then you have the apical two-chamber. You have that patient lay in the lateral decubitus position on their left side, and you're going to put it kind of alongside the nipple line, mid-clavicular, I would say. More towards the axillary, and you're going to be able to see, let me see. So it's best for patients that have, let me go back. Primarily for the evaluation of the anterior inferior walls for right wall motion abnormality or regional wall motion abnormality. I don't do it a lot. You know, the major views that I've done are really these ones, the PSACs, PLACs, and the apical four-chamber, but this is just for completeness sake, I wanted to put that in there. And then you have the subcostal long axis, which Dr. Duffy also talked about last week. It's good for patients with COPD where you might not be able to get views by putting the probe on the chest in that third, fourth, or fifth intercostal space, because air is not really the best medium for an ultrasound transducer probe. It can be hard though, because it becomes somewhat painful for patients where you're putting it right at that xiphoid process and then kind of dipping in. So again, you might have to push downwards. It could be painful, but you can get some pretty good views here. You can see the left ventricle, the mitral valve, and then the right atrium. So the mitral valve's here, the left atrium into left ventricle, right ventricle from the right atrium with a tricuspid valve. So you can also get a four-chamber view if you're able to get a good, in the right patient, in the right body habitus. And as Dr. Duffy kind of mentioned, this patient they had on Team A, since they were thin, it was a good option for them. So looking at TTE in specific scenarios or at ACS, you can look for unexplained hypertension or murmurs. Maybe you're worried about a pericardial effusion that's also happened as a result of ACS. You can help look for ischemic heart disease, looking for that wall motion abnormalities and PSACs or PLACs views. It's going to be very sensitive versus the stress ECG, because you're getting good anatomic and functional views to decide if there's a functional component or a reason why you need to intervene on this patient that you're seeing some findings and symptoms in. You can also look at aortic dissection, right? Because in the previous films, I showed you that you had a good view of the aortic root and even the descending aorta coming in. The TEE is clearly going to be more specific and sensitive for that, but it's very invasive, obviously. So the TTE is something you can do at the bedside to help do. This is just a summary of all the different views that I put in one slide with the anatomy. I'm not going to go through each one of these, but just for you guys to have when I send this out. Here's some echoes that I put in. So this is an example of someone who had a PE. So you can look for the effects of a PE and evaluation of submassive or massive, and you're going to look for that dilated right ventricle. So we have the left atrium here, and then we have the left ventricle going into the aorta. And then we can see there's some bowing into that septum as well with that right ventricle as well. So the parasternal long axis, but the left walls are somewhat thickened as well. You can see some thickening. Sorry, I know it's just, but really the thickening is seen right here. So it should really, the fact that you're seeing such thickening might lead you to think that there's some pulmonary retention or some other process going on that's resulted in the right ventricle having to accommodate for those increased pressures. This one's not, oh, I don't know if I'm able to have this on repeat, but you can also look for arrhythmias. Obviously not the best option for arrhythmias, but specifically for left or AFib, because if you're going to see that left atrial dilation, then it's going to be clearly a sign that this person probably has had long-standing atrial fibrillation. In this one, you can see a hypokinetic apical left ventricle. So just, it's not really, contracting much at all. It's most consistent with a thrombus in this specific setting, but this is one where you just don't see really good inward motions of the valves, or the walls, I should say, sorry. So I think this is the last slide. So we've talked about a lot in 2 different sessions. We talked about chest x-rays initially, looking at pulmonary diseases, but mostly cardiac diseases. That we talked about pericardial effusions, that Oreo sign, if you recall, I talked about, as well as just being able to see, we talked Takasubos as well, can be seen very well in a chest x-ray. We went over the importance of a pre-test probability in deciding stress tests and knowing that the exercise ability or inability is going to be your first kind of cutoff point versus whether you're going to do pharmacologic interventions versus the patient exercising themselves. Knowing that cardiac CTA, which we talked about a lot today, is an emerging modality that's going to start competing with stress testing, but it just doesn't give us that functional component that we would like. And we briefly went over transthoracic echocardiograms, but I urge you to look at Dr. Duffy's discussion because he went into more detail about that, because it allows us to give us more information about the heart. And as he likes to say as well, it's kind of replacing the stethoscope as an immediate option that we can do at the bedside of getting more information than the stethoscope can provide. And then we talked about the cardiac calcium score for asymptomatic patients, where you're having that discussion about whether or not a statin or aspirin would be beneficial in them, and you can use it for risk stratification in the right age group, right? Remember, because we talked about the 30-year-old, but we wouldn't apply that to that patient because they weren't even in the right age group. And then we finished all with Holter loop and implantable loops based on the frequency of symptoms, deciding which one to do in our workup for cryptogenic strokes, atrial fibrillation, palpitations, PACs, PVCs, etc. That is it. And that's the first time I've completed, well, it was half of a lecture though, on time. What questions do you guys have for me? Looks like no one has questions. All right. Well, thank you for paying attention. And the next lecture we have, so today's the 13th, will be case and then unstable anginas by Dr. Ayler. She's been spending a lot of time on that. And there'll be an OMEM lecture with Dr. Schultz. The next time I'll be lecturing will be next Wednesday. I'm going to do perioperative evaluation. All right. Thank you all. I'll see you all later.